Hello and welcome to today's webinar, everyone. I am Trevor Smith-Miller, the Communications Manager for the Canadian Cancer Survivor Network. Thank you everyone for attending today's webinar, and this is our first of the 2023 Fall Series. If you are new to our webinar, a little background on our group. CCSN is an organization working with cancer patients and survivors to learn about the complexity of our health system, connect with others to plan action, and act on those plans to create better outcomes and healthy survivorship. Please visit our website to find plenty of information like news, events, and our webinar series. Now, this webinar is being recorded and it will be available on YouTube, and a link will be provided by the email that you registered with, along with a link to the slides provided with this presentation. Now, we will have a quick Q&A session at the very end, but if you would like, please put in your questions in the chat or in the questions column on the right side of your screen. And now to introduce this week's presenter, a special one for Prostate Cancer Survivor Month, André Deschamps. André has a background in chemical engineering and has held several management positions in manufacturing. However, after being diagnosed with prostate cancer at the age of 51, he developed an interest in the way cancer patients are treated by medical staff and their quality of life after prostate cancer treatments. In 2011, he joined the WIJ Belgium Cancer Group and was elected as chairman in August 2013. In June 2014, he became a board member of Europa UOMO, the voice of men with prostate cancer in Europe. He served as a treasurer and was elected chairman in June 2018. And since June 2022, he is now a past chairman, serving instead in an advisory role. And so without any further ado, I will pass along to Mr. Deschamps to present his talk, The Real Burden of Prostate Cancer Treatment.
Okay, can everybody see my screen?
Yes, we can.
Okay, welcome to this webinar. I'm André Deschamps, as Trevor said. Thanks for the nice introduction. And what I'm going to do tonight, I'm going to show you the results of our Euproms study. Why Europa UOMO did the Euproms study? Well, talking to patients and listening to healthcare professionals and looking at the results of the clinical studies, we found a discrepancy between the two. So we decided to design a survey and present that through our membership so that patients could tell us exactly what their burden was after any treatment for prostate cancer. So it is the first ever survey in prostate cancer from patients for patients, and I will show you the results of the two studies, which is called the Euproms 2 and the Euproms 1 study. As I said, was done the study initiated by Europa UOMO, which is a coalition of 27 members in different states in Europe, and the team was consisting on the Europa UOMO side, myself and Ernst Gunther Kauer and John Darling. Because we are patients and we are not that familiar with statistical data and analyzing data, we have formed a coalition with the Department of Urology in the Erasmus Cancer Institute in Rotterdam. And that's Professor Monique Robel, who is one of the famous statistics in prostate cancer, with her team, Sebastian Lemmers and Leona, and they have done the analysis for us. Some general comments before I start really with showing you the results. There is an underrepresentation of Eastern Europe. There is a slight bias in respondents' profile towards a higher education, which is not, which is very common, I think, if you do a survey like that. And about 60% of all the respondents had a radical prostatectomy, hence the overall results will be influenced by the quality of life effects of that treatment. It was a sample size of more than 5,000 respondents, which makes the result very reliable. And you must realize that the presented results are a snapshot at the time of the survey when we asked the patients to give their views. The results have been peer-reviewed in different articles in important places, and I'm just showing you the one that was presented in the European Urology Focus, and you can read that, you can find that everywhere. Before I go further, I must say that the results of this study are the result of patients telling us what they were suffering from. So they are available and you can use them. Any patient can use them as long as you mention the source. Let's talk about the methodology, the sample, and the treatment profiles. Here is an overview of the surveys. It was about 20 minutes online questionnaire. The respondents could answer in any of the 19 European languages they want. Where we could, we used validated questionnaires like the EPIC 26, the EORTC, QLQ C30, and the EQ5D50. You will see later in the presentation that that allows us to compare the results in clinical studies with the results of the survey. Of course, the responses were anonymous, and in the first survey we had 2,953 answers. In the second survey, 3,570 were from 2,544 new ones. So in total, the combined results I'm going to show you today are representing 5,500 nearly answers. And that's a big amount because if you set that off against all estimated cancer patients in Europe, it's 0.25% of all the patients in Europe that helped us to collect those results. The difference between the Euproms 1 and the Euproms 2 is very simple. When we did the Euproms 1, we got, especially from the healthcare sector and the healthcare professionals, some comments like, you have not asked for tumor characteristics and Gleason scores, and you have not have a good answer of the comorbidity. So those were things we corrected, so to speak, in the second study. And there is also a following up study after 1 year where we are analyzing the results today. Geographically, you can see here that we had answers from 32 countries, and important, especially because I'm speaking for Canada and the United States today. Canada gave us 234 answers in the second survey, and USA nearly 100. A comment to make, and an important comment to make, is for all the countries where we had more than 100 answers, we tried to have specific answers for the country, but we realized that statistically there was no difference, no significant difference between the countries. So we skipped that route, and I can tell you today that the total result is statistically relevant for any country that gave us an answer. Furthermore, on the responses profile, the living situation, 82% of all the patients that answered were still living with a partner, which is of course very important to realize, because a lot of the effects are not only a burden for the patient, but also a burden for the partner. 14% was living alone and 3% with family. And here you see the slide bias in the education, that about 63% did university degree or had a higher college certificate. This is also important to realize that the average age of the respondents was 70 years, and that was approximately 6 years after that diagnosis. So all the bias that is there in the first year after your treatment is gone in the results. But it also tells me that the statement that is often made, at least here in Europe, that PCA is an old man's disease. No, PCA is not an old man's disease. You see that 42% was younger than 65 and 76% was younger than 70. Now, if 70 is old, then I'm a very old man, by the way. Looking at the treatments, you see that radical prostatectomy, which is here shown as RP, was a major, about 60% of the treatments, and the rest was divided, single or combined treatments. So you can see here the graph. But what is important, because one of the comments we got after Euproms 2, or Euproms 1, sorry, was those are all data. Well, those are not all data. 80% of the treatments were after 2015, and about half of the treatments were after 2020. So the latest techniques of the treatments are in. And what is also important to realize, if you look at ISUP1 or Gleason 6 patients that answered, there was quite a bit. And you see here that a Gleason 6 and a Gleason 3+4, which is ISUP2, is still treated with radical prostatectomy or combinations, which in fact should not be the case. We should use active surveillance, as I'm going to show you later in the presentation. Are there differences between the countries? Yes, there are. Look at Canada. Yeah, you see that there's a relative big amount in Canada on active surveillance if you compare it with the other countries. And you can see the same in the US, although I must say that the distribution of the link in the US was done by an active surveillance group. So that may explain the bias where, so that you see that in the US, active surveillance is overrepresented. Now look at the general quality of life, and this summarizes, in fact, the study. You see that your sexual function is affected the most after treatment for prostate cancer. Urinary incontinence is the next one, and you may have hormonal problems, urinary obstruction, and bowel effects. And I'm going to show you details a little bit later. Let's first look at the discomfort, the insomnia, and the fatigue factor, which is represented in the study. And you see in this slide and the following slides that, in fact, it's always the same. If you are on active surveillance, yes, of course, there is a burden. Radical prostatectomy and radiotherapy, which are the first line treatments, are also giving you a burden in pain and discomfort and mentals, as you will see later on. But once you are in a metastatic phase and you receive radiotherapy and ADT or chemo, your burden increases by more than doubling. So those are the results of the EQ5D. You see each time on the slide where the results come from. Similar for the tiredness, more than a third of the men who have received chemotherapy say they feel tired, and same for insomnia. Now, if you look at the impact on the mental health, then you see that 42% of the men say they are anxious or depressed to some extent after the treatment for prostate cancer. And you also see in the study that recurrence that often is there after the first treatment is giving you or is having a major effect on your mental health. And you see here again the same thing, active surveillance radical prostatectomy first lines are having an effect, but the effect doubles when you go into the metastatic phases. Let's look at the impact on your sexuality. We have seen on the summary graph that sexuality is impacted the most. And here you see the results of the EPIC function. Now, I must explain you a little bit how that is measured. EPIC 26 is asking you 10 questions on your sexual function, and it's every time a score that you give from 1 to 5, those added are added up to or recalculated into a maximum of 100. So a young man without any sexual problem at all is having an EPIC score of 100, which is the best possible score. And the lower the score is, the more affected your sexual function is. We must also realize that in this age group, the sexual function is no longer the maximum. Yeah. Sometimes erections and orgasms are less, even in men not having a treatment for prostate cancer. So it's important to realize that the reference score for healthy controls without prostate cancer in that age group is 61. So we may say that the maximum a man can have in that age group, averaging of course, is a score of 61. Furthermore, if you look at those kind of graphs, it is a plot. So what it shows you, I take here as an example the active surveillance group. There are men that are scoring 85-ish, which is very good, but also there are men with less sexual function at that age. So you see in the plots, you see every time that spread. Yeah? But we speak here about the median, and the median for active surveillance is 58, dropping by 1/3 for all the other treatments. And what was a very big surprise for us, that the radiotherapy groups had no better results than the radical prostatectomy groups. Because if you read articles about that in clinical studies, they have told us many times that the radiation therapies would give us a much better sexual function than radical prostatectomy. And that is not the case. That is not what we found. And I remember about 1/4 of all patients in Europe answered this questionnaire. So in summary, radical prostatectomy and radiotherapy both give you a major reduction in your ability to function sexually. And an ability on your sexual life. Now, what does that mean for patients? Those are figures. What does that mean? Well, you see here again that once you are treated, you must know that your sexual function is going to be around 20. Yeah. And what does that mean? Well, there are two things important for men, I think. That's the ability to have an erection and the ability to have an orgasm. And we have separated the two questions in the questionnaire, and you can see that the result here. So as long as you are in active surveillance, 58% of the men report to us that they still have very good erections, which is only 20% after treatment with radical prostatectomy or radiation. The ability to reach an orgasm is slightly better with the patients who received radical prostatectomy. You can see that here, and seems to be scattered for those who received treatment with radiation. Now, we must realize that in most of the cases, radiation is combined with ADT, and that causes, of course, another drop in the ability to reach an orgasm or have an erection. Now, often healthcare professionals tell us, yes, but after ADT, there is no longer an interest in sex, or after a treatment for prostate cancer. Well, our study tells me that that is not the case. There is a scattered interest in sex with a lower tendency towards the combined treatments, but still a lot of the patients, about 50% in the early stages of the treatment, and still 25 to 30% in the later stages, have an interest in sex. Yeah, so it is not because your ability goes down that your interest goes down. And you see that 75% of the respondents rate their sexual performance, their own sexual performance, poor to very poor, and only 25% rate their ability as good. And you see that it is a problem. I mean, they perceive that as a big problem. About 50% of the men tell us, yes, for me, it is a problem. It is a big problem or a moderate problem, which is not surprising if you realize that still 82%, as I showed you, are living with a partner. Is there a difference here? How big as a problem you see that between prostatectomy and between radiotherapy? There is a difference, but it's not that significant. You see here 54 for here, 47, see that as a big of a moderate problem and a small problem. The figures are about the same. Now, what was also a big surprise for us, if men see that as a problem, have they tried to do something on it with medications or devices or ask for help? And we realized after the study that only 33% of the patients have done efforts to mitigate their problems, although we know that there are a lot of medications and a lot of other things that could help us to have still a sex life. But here you can see that only 32% of the entire cohort, with some treatments it is more than others, but have not tried to do something about it. And that is a shame. Whether it comes from a lack of knowledge what solutions could be, that's certainly a point of interest that we as support groups must look at to make sure that men get the best advice if they struggle with those things. Let's now look at the impact on urinary incontinence, which is also a big impact. And you see here the same plot as you saw for sexual function. Of course, here the reference for healthy scores for healthy controls without prostate cancer is 92. which means that most of the men in that age group have practically no problem with incontinence. You see also that the spread for the active surveillance group is very small, and the median is even 100. And you see that there is a big spread for the men who have been treated with radical prostatectomy, and a smaller spread for those men who have been treated with radiation. And the average is, of course, you see also that radical prostatectomy gives a bigger problem for that element incontinence than you see for radiation. We have just asked the men, and I'm now focusing on one of the questions that was asked over the past 4 weeks, or often have you leaked urine? And then you see that for radiation, it's 33% of the men who say, yes, I have had problems. And for radical prostatectomy, it's nearly 60% of the men. Now, we all know that in the first year after the treatment, that can improve. Yeah? But it was still a surprise for us that 32% of radiation patients have problems with this. We thought it was going to be far less. And what does that mean for men? Well, it's of course pad use. Yeah, and you see here that 35% of the patients on average use pads. Most of them 1 a day, but some 2 and more a day in order to cope with their incontinence. And is there a difference between radiation therapy and radical prostatectomy? Of course there is. It's not surprising. It's 70% that uses pads for radiation therapy and 47% after radical prostatectomy. What I must say here is that healthcare professionals and urologists tell us that with the latest techniques used for radical prostatectomy, the result is going to be better, but that is at least not shown in the study that we did today. Do patients see that as a problem? Yes, they see it as a problem. As you can see, 60% is perceiving this as a big problem and 42% as a small or a very small problem. Possibly the ones who are only using one pad have learned to live with the incontinence. Is there really a difference between the two major treatments in the early stages, radical prostatectomy and radiation therapy? Yes, of course there is. We have already seen that radical prostatectomy has a risk of bigger problems with incontinence than the radiation. Now, what was also a surprise for us is that there are other important results out of the EPIC 26 with a big impact on quality of life. And I'm going to show you some. Bleeding with urination seems to be a bigger problem than we all thought. And here it is radiotherapy, 6.7% of the patients, compared with radical prostatectomy, only 3% that is having problems, with, big or small problems with bleeding with urination. Weak urine stream or incomplete emptying, you see here again that radiation gives bigger problems than radical prostatectomy, although I must also see that it about half of the 65% report that it is a small problem, but it is still a problem. Look at the urgency to have bowel movements. There we see for 54% having problems after radiation therapy, and after radical prostatectomy is only half. So in all those elements, it looks as if radical prostatectomy are giving you less problems, but radiation is giving you the risk of more problems. Increased bowel frequency of bowel movements, we see exactly the same picture. It's 42% for radiation and 22% for radical prostatectomy. And again, about half of the problems is a small problem, and half of the problems is small or even bigger problems. And you see every time in all those graphs that I'm showing you that the moderate and the bigger problems for radical prostatectomy are much smaller than they are for radiation therapy. And that was a surprise for us. It's similar for losing of control of stools, where you see here that about 15% is having problems which are bigger, and that's not the case for radical prostatectomy. And the last slide in that area is bloody stools, and the picture is about the same. Now, what we also did in our Euproms study was asking after the shared decision making. We did that in the second study. There is an SDMQ9 questionnaire which is validated, and what it does, it is asking you 9 questions on shared decision making. Have you been informed? Were you part of the decision for your treatment, and such things? I will show you the detailed questions later. And the maximum score you can have if you feel that your shared decision making was excellent is 45. So you have 9 questions, 5 points as a maximum each, which gives you a maximum score of 45. And if you look at the overall scores, we found for all the treatments, for nearly all the treatments in the study, averaging the total, you may say shared decision making was not that bad. Yeah, you see here scores averaging from 30 to 35, which is in fact not a bad score at the first view. Is there a difference between the countries? Yes, there is definitely a difference between the countries. You can see that Canada is better, yeah. USA is better, and in some southern countries like Portugal, the shared decision making is worse, yeah. And that's not surprising, because the taboo in Southern Europe and Eastern Europe, but we did not have a lot of results from Eastern Europe, as I told you. The bigger the taboo is, speaking about the disease, the less shared decision making is. But there is one remark to make, and here you see the questions that are asked, and my doctor and I reached an agreement on how to proceed and so on. You can see them. Then if you look at in my view, the more important questions, my doctor and I selected the treatment option together. And my doctor and I thoroughly weighted the different treatment options. And the doctor asked me which treatments I prefer. Then we see much lower scores, averaging 25 in that area. So the other questions are boosting the results up, but for the patient, the three more important questions are still not answered and shared decision making. Therefore, I say there is still work to do. Other remarks on the study are what were the self-reported comorbidities, because of course they can influence the results. You see that 55% of all the patients did not have any self-reported comorbidities. High blood pressure, which is for that age group, of course, not surprising, was 26. But for the rest, there were, in fact, not that much comorbidities that could have influenced the results of the study. A question often asked is, do younger men have better outcomes? Yeah, the younger you are, the better your general health is, and maybe your recuperation is better. Do we see a difference in younger men compared with older men? Well, here you have the graphs. For the sexual score, yes, there is of course a difference, but the score even in younger men is still not higher than 25, where the averaging before the treatment, I remind you, was about 60. So there's still a big drop in your sexual abilities. And what you see in the incontinence is that there is hardly a difference in incontinence score. You may say that if you are younger than 64, your recuperation of your ability is a little bit better, but it's still a major impact. And when you are older, you may reckon that you will have incontinence problems after your treatment, because you see that indeed here we see that younger men are doing a little bit better than older men. And if you look at the pad use, of course, this reflecting the two upper graphs for the pad use. Do I have a better outcome when my ISUP grade is lower than it is higher? Well, the answer is no. I mean, once you have a treatment independent of your ISUP score, look at the incontinence for the Euproms 1 total, which is the blue one, and the ISUP 1 to 3, so the Gleason's 6 or 7, which is a 3 plus 4 or a 4 plus 3, there is absolutely no difference in incontinence. And there is also hardly a difference in your sexual scores. So the grade, the Gleason grade or the ISUP grade in the newer does not make any difference at all for your outcome after the treatment. We also look at reasons for PSA testing. You know that when you don't look at your PSA, you cannot hardly detect the cancer unless it is in a metastatic phase. And which is, I think, good, is that 45% is having a routine blood checkup, or is 25% is asking a test at their doctor, which is, of course, not bad at all. What diagnostic tests are used once you are having a treatment or must have a treatment for prostate cancer? We see that biopsy, MRI, bone scan, and of course in the later stages, CT scans and ultrasound, that all the tools we have at the moment to decide on the treatment of prostate cancer are used. I'm nearly coming to the end of my presentation, but very important is, I told you that the beginning and the reason to do this study was, is there a difference between the results we see in the Euproms study and the results seen in clinical studies? Because that was really the reason why we started this important study. And the answer is yes, there is a difference. I'm showing you here two studies. One is the study, is a study which is a combined study of all the big studies done in radiation. So it shows you here, depending on the study, the drop in sexual ability after the study. And you see that all the studies are showing far less drop than we did. We showed an average, or patients are reporting an average of only a sexual ability of 17. And you see that there is only one study here that is going so low. So that's decline over time. And Euproms is about 60 months after the treatment, as I showed you. So our Euproms point is here. Oh, sorry about that. I need to. And when you look at the Donovan study, which is also a very important study following the sexual function over time in after treatments, there you see that the blue line is active surveillance. They show in active surveillance a much lower result than the patients that were reporting to us in active surveillance. And for radical prostatectomy, the red line, and the orange line, the treatments with radiation, you see that we are lower. Now, one of the results, or one of the reasons why the result in active surveillance in the Donovan study is so low is that they classified the groups in the beginning of the study. And when an active surveillance patient was having a treatment later in the study, they did not reclassify. So in their line of the study, you find patients that were having radical prostatectomy or radiotherapy later in the study. Now, what are the take-home messages? And then I'm going to open the floor for questions. Take-home messages: quality of life after treatment. I've showed you this slide, but it's a summary slide. Sexual function, urinary incontinence, and hormonal urinary obstruction, and both effects are and your sexual function and continence function are affected the most. Early detection is key, and quality of life deteriorates with progress of the disease. You see here the discomfort, the fatigue, the insomnia, and the mental health. You see that it doubles, the problems doubles after when you go further in the journey. And active surveillance should be the first option in order to achieve the best quality of life when it can apply safely, of course. Here you see again a summary in incontinence and in sexual function. So there is no question that active surveillance should be the treatment as long as you can have it in safely, of course. So the results of the study combined provide a different and additional perspective compared to the outcomes published in clinical studies. They should be discussed with the patients before the treatment. They should encourage better and longer aftercare. And last but not least, we have done a follow-up questionnaire 1 year after the study, and you may expect those results later this year. And the last thing I like to mention is that because 82% of the patients are living with a partner, we have decided to measure the burden on the partner, and that's a questionnaire that we are going to launch as from October 1. And I invite you all, or the wives, of course, of the patients or the partners of the patients, to answer that questionnaire, so that also there we have a very good view what the burden of the disease is. Thank you.
Thank you very much, Andre. That was a fantastic presentation. And if you guys want to see the presentation, we will have this up on our website, and we will be sending you a copy of the presentation to your email when this is done. If you have any questions, I'd like to encourage anyone to write them down in the chat. We already have a comment from James Varga, who says that in BC, PSA routine screening is now suspended. British Columbia, the Canadian province, you have to have symptoms before a GP will do a PSA test. And he thinks this is short-sighted by the BC government. But a lot of there's been a lot of positive talk about PSAs. And Andre, if you could talk a little bit about that, is whenever you were researching PSAs, did it seem like that in general, that it seemed like that it was a very positive aspect? And should people have symptoms, should people get this test before they have symptoms?
Yeah, well, it's very clear that prostate cancer in the early stages does not have symptoms at all. So you cannot detect prostate cancer. A lot of men, also here in Europe, they think that if they have problems with peeing during the night, that it's prostate cancer. No, it's not prostate cancer. It's usually your prostate that grows a little bit due to age. So that has nothing to do with prostate cancer. There's a big debate here in Europe, and I'm sure it is in Canada and it is in the United States. What are we going to do with screening? You may know that there is an advice from the European Commission to go for screening here in Europe. There's still a very big resistance in a lot of countries to do that. But of course, we as support groups, we are at war for those governments who do not want to do screening. So I think my honest view is today we have all the methods to avoid overtreatment. Yeah, we know what we need to do for active surveillance. Is it reality? No, it is not reality. There are still a lot of healthcare professionals who treat where they should not treat us. So there's still a lot of work to do. But no man should die from prostate cancer those days. We have the methods to screen. We know how to screen. There is a very good article made by the EAU, how to screen with the help of MRIs, even not doing biopsies. So we have all the knowledge today how to make sure that men get the best treatment, and we are not using it. So that's a shame.
Mm-hmm. Now, looking at just, again, active surveillance was constantly one of the things that in your presentation that said this needs to happen. But I mean, there could be situations that a doctor wants to push this kind of treatment, saying this, but how does a patient advocate for themselves, saying, I would prefer to be under active surveillance? Like, what kind of words do they need to say? What do they need to talk about to make sure that they're not overtreated, as you said, to just maintain this active surveillance so that they don't have to deal with all these side effects?
Well, I think one of the methods to overcome the overtreatment problem we have is make sure that treatments are only done in cancer centers with multidisciplinary teams. I believe very hard in that. We see in Europe, and again, I'm not aware of the Canadian situation, but in Europe at least, we see that where patients are referred to cancer centers and treated in cancer centers, the risk of overtreatment is much, much less, because they inform the patients about the loss in quality of life, and they help the patients with the psychological burden of being in active surveillance. So I think the thing is, break the taboo, inform the man, make sure that active surveillance is available, treat them in cancer centers where they can be sure that treatment in active surveillance is still safe. And that is the way to go.
Mm-hmm. One other question that we had, I can direct you to the list of papers that Mr. Wasserung has part at the bottom, but he has said that the EPIC 26 method it has some problems with it as a survey method, and so he was wondering why you were using the EPIC 26 as a survey instrument.
Oh, that's a good question. Any instrument has its pros and its contrasts. Yeah, but I believe that. Well, why we have used the EPIC 26? We've used the EPIC 26 because that allows us to compare with clinical studies. I mean, the EPIC 26 is used in a lot of clinical studies, or I say it in other words, where quality of life measurement is done in studies, it's usually EPIC 26 that is used. And you can complain about some of the questions in EPIC 26. Yes, that's true, but it is an instrument. And I still believe that the general conclusions will not change. I mean, you may use another instrument and find a little bit more or a little bit less of a burden, but generally speaking, it is not changing. You must also realize that 10 points difference in EPIC 26 is not significant. So it's only when you find differences of more than 10 points that it is significant. But look at the figures that we found. It's from an average of 60 dropping down to 20. Well, that's 40 points. So it may be 30 points or it may be 10 points, but it is a significant drop.
Alrighty, and with that, I think that we are out of time. So once again, I'd like to thank you, André, for a fantastic talk. Thank you very much. And once again, the survey results and this webinar will be up on our YouTube page and on our website. Now, this is one of a series of webinars that we are presenting this fall. Our next one is actually next week. It is about asbestos in drinking water in Canada. So to stay in the loop about webinars, visit our website or check your email for our e-blasts about our webinar series. Now, if you're not seeing that in your email inbox, a lot of email services like to have multiple inbox. Check each one of them. Check your spam folder because we do use a third-party email services. And if that doesn't work, just make sure that you are subscribed to our newsletter, and you can go to our website for a slide on that to subscribe to the latest of what we're doing with our webinar series and what we're doing here with CCSN. And you can see all of the webinars we've done since the very beginning at survivornet.ca/webinar or on our YouTube channel. So once again, André, thank you very much for a fantastic presentation. I hope that we will see you again, and let us know what happens about that survey, the follow-up survey, coming up later this month.
Okay, my pleasure. Thank you.
All right. Have a good night, everyone. Thank you very much.